Okay, let's pick up from where we stopped. We are continuing with birth injuries. In the previous presentation, we looked at injuries to the skin, which we said they are basically iatrogenic, caused by our tools we use during delivery. So, and under this, we looked at abrasions, we looked at cuts, and then we went ahead to look at cephalohematomas, which are brought about by tearing of minute blood vessels under the periosteum, and then a capotis externum, which is a collection of serosigenous fluid above the periosteum, below the scalp. So that is what we looked at in the previous presentation. Let's continue to look at birth trauma. This time, let us look at muscle traumas. And under muscle trauma, the first injury is called a torticollis. A torticollis is mostly damage to the sternomastoid muscle, the right and left sternomastoid muscle. A sternomastoid muscle is this muscle running from behind the ear, and it is coming and hiding into the from the sternum, and it is coming and hiding through the mastoid bone. And its role is to make our heads turn from side to side. And when one of the sternomastoid muscle contract, for example, when my right sternomastoid muscle contract, the head will be pulled to the right, and then it means the left sternomastoid muscle will relax. And this is the same on the left side. When the left sternomastoid contract, the head will pull to the left side, and then the right one will relax. Whereas when both contract, the head will be pulled to the front, and whereas both are relaxed, the head will be pulled to the back. So the injury which is going to affect the sternomastoid muscle will affect the baby from turning the head from side to side. Excessive traction or twisting causing tearing of one of these muscles can occur during birth of the anterior shoulder of the fetus with a cephalic presentation, or during rotation of the shoulder when the fetus is being born by vaginal breech or cesarean section. In most cases, when you look at our mechanism of labor, there is that stage of when the head escapes, and then crowning. When the crowning occurs, the head will escape, then there will be restitution. So after restitution, the midwife will grasp side to side in between the ears of the fetal head to deliver the baby laterally onto the maternal abdomen. So during that process of delivering the baby laterally onto the maternal abdomen, the sternomastoid muscle can be injured. That is when we are carrying out vaginal delivery. It can also be affected or injured when we are delivering a breech, like when we pull on the legs and we are having the aftercoming head, and then we apply the traction. This baby can be injured. The sternomastoid muscle can be injured. On examination, usually it is painless, and a hard lump of blood or fibrous tissue can be felt on the affected side of the sternomastoid muscle. The muscle length is shortened, therefore the neck is twisted to the affected side. For example, this side is affected, this muscle will be shortened. It means the head will be pulled onto one side of the body, and we shall call it a torticollis or in a normal language, people will call it a ray neck. So, how would we prevent it? Before we prevent it, how would we know? We shall know when the baby is not able to freely turn the head. And the mother will tell you that when I turn this neck to this side, the baby cries. So we shall understand that this baby sustained a ray neck, or the baby sustained a torticollis, which is injury to the sternomastoid muscle. And how would we prevent it? We shall have the techniques of assisting the second stage of delivery, and we apply the methods very gently. When the head is out, let us have that patience to wait for restitution and know which side of the baby's head is turning to, and then more extension of the head and delivery of the shoulders will occur that will aid us to comfortably deliver the baby's whole body onto the maternal abdomen. In breech, while delivering the breech, we should have that patience to wait and see the nape of the neck before we apply that 180 angle to deliver the aftercoming head onto the maternal abdomen. So that is one of the key preventive techniques to a torticollis or to a ray neck. So if it is witnessed to a baby, what can we do? So the management will involve the caretakers and the parents performing passive muscle stretching exercises under the guidance of a physiotherapist, and actively encouraging the baby to move the neck. The swelling will usually resolve over several weeks to months with minimal sequelae. Minimal sequelae means with minimal injuries. And usually we may not need any surgical intervention, and usually by 1 year this baby will be out of danger. So that is why we said that each injury we should make it be known to the parents, and we should teach them on how to handle it. Okay, let's continue with the nerve trauma. Under the nerve trauma, we are going to look at the nerves that are susceptible to injury during birth. And the common nerves traumatized are those nerves which supply the face and the bronchial plexus. The bronchial plexus are those nerves which serve the upper limbs or the arms, and then those nerves which serve the face. The spinal cord injury are rare, but we may not exclude them completely. They may also be there. But let us look at the common nerves injured. And the common nerve, one is called the facial nerve. The facial nerve has its roles. One is to move the muscles that involve the face, including speaking, including chewing, smiling, and facial expression. So it is a role of a facial nerve to have all those functions. So now, when the facial nerve is damaged, and the facial nerve is the 7th cranial nerve, it usually results in its compression against the ramus of the mandible by the forceps, resulting into unilateral facial palsy. So when the facial nerve is affected, the baby will have what we call a facial palsy, or another word is called the Bell's palsy. That is another word for facial palsy. And how will the baby look like? There is unilateral facial weakness, or with the eyelid of the affected side remaining open and the mouth drawn over to the normal size. If the baby cannot form an effective seal on the nipple or teat, there may be some initial feeding difficulties. Here we mean that when the facial nerve, one side is affected, usually it is unilateral, one side of the face is affected, and it will produce a weakness on one side of the face. And the side which is affected, the eyelid will not be able to close. It will remain open. So the baby may fail to close the eyes on the affected side. And then the mouth, that very side, will be drawn to this normal side. I'm assuming that the right side is affected, the eye is remaining open, and this mouth, this side which is injured, will be drawn to the normal side. If the baby cannot form a firm grip, it means one of the key examination is to examine for the sucking reflex. And when we try to put a finger in the baby's mouth and this baby cannot form an effective seal, it means there might be a damage on one of the side of the baby. So this is a typical example of a Bell's palsy or a facial palsy. This baby's eyes both are closed, but when you look at this mouth, it is pulled to one of the side. It means this side which it is pulled for is a normal side, and this side whereby the mouth is partially closed or open is the affected side. We expect even the eye on this side to remain open depending on the extensive damage, the extent of the damage of the facial nerve. Now for this baby, maybe the nerve supplying the eye was not. But if it is damaged, this eye will remain open and this mouth would be drawn to the normal side. And this is a typical look of a baby with a facial palsy. Management. We have no specific management. If the eyelid remains open, regular insulation of methylcellulose eye drops, which can help replicate the eye. One, because closing the eyes is one of the protective measures of the eye. So it means if this eye cannot close, this eye is prone to infection. And because this baby cannot form a firm grip, this baby will find feeding difficulties. We have said that management of a facial nerve may not be specific, but because the eye can remain open, we may need to insulate it with eye drops. And then if this baby is having difficulty of gripping the nipple, this baby is having feeding difficulties, of which this baby can be helped on alternative feeding, either by use of a spoon, and if it is very difficult, we may be coerced to pass a nasogastric tube. But usually if it is not very severe, it usually resolves within 7 to 10 days. And during these 7 to 10 days, we teach the mother on how to feed the baby using a cup and spoon. Yes. And we've said another injury can occur to the bronchial plexus, and the bronchial plexus is a group of nerves that supply the upper arm. Their use: one is the lower bronchial plexus helps us to grasp. The grasping reflex is aided by the lower bronchial plexus, and then alteration of the hand is also affected by a group of nerves of the upper bronchial plexus. So this group of nerves result in lateral flexion of the hand, rotation, traction of the head, and the main injuries which occur to the bronchial plexus, we have the Erb's palsy, we have the clamp case palsy, and sometimes a total bronchial plexus palsy. So let us look at one by one. One is the Erb's palsy. Erb's palsy, there is damage to the upper bronchial plexus involving the 5th and 6th cervical nerve roots. It is the commonest nerve injury, and its cause is overstretching or twisting of the neck in vertex or in breech deliveries, excessive lateral flexion of the neck in delivering the shoulder in vertex, and a prolapse of the arm, for example in transverse lie. These are one of the causes of the Erb's palsy. So how does the baby look like? The baby's affected arm is inwardly rotated, the elbow is extended, the wrist is pronated and flexed, the hand is partially closed. This is commonly known as a waiter's tip position. The arm is limp, although some movements of the fingers and arm is possible, and the Morrow's reflex is absent, but the grasp reflex is good. Let us try to look at this baby. In normal cases, the babies after delivery, all the hands should be in good position. They should be able to come onto the abdomen like this hand. But now when you look at this hand, when you look at this wrist, the wrist is pronated, it is going out. And these fingers are partially closed. They are not like these ones. And this partial closure of the finger names it the waiter's tip, because the fingers are partially closed and the wrist is pronated. And this hand is extended instead of being flexed. Otherwise, this hand should be here, but the hand is extended. Now, when we carry out a Morrow's reflex test, we expect both these hands to come up as if they are grasping something, or as if the baby is falling down. The baby should find out where to touch. So when you do a Morrow's reflex, this one hand will come and this affected hand will not come. It means the hand is affected right from the upper extremity. So this means this hand has what we call the Erb's palsy. The hand is pronated, is extended, the wrist is pronated, the wrist is pronated, the hand is partially closed, and that is why they call it a waiter's tip, because it is partially pronated. And when you try to do a Morrow's reflex test in this affected hand, the Morrow's reflex will be absent. But when you try to put something in this hand to test for a grasp reflex, this baby will be able to grasp. So that is a key characteristics of an Erb's palsy. So management of an Erb's palsy, the arm is immobilized by splitting the arm in an abducted and externally rotated with the elbow flexed. So the hand this hand will be brought back in the right position, and then it will be bandaged in that position. And after bandaging it, we shall get that bandage and tie it on the baby's coat, because if it was an adult, we will instruct the adult not to turn the arm, but the baby may not be able. So after putting it in the position we wish like, we would tie that position and secure it on the baby's coat in order to minimize movements. A padded bandage may be applied around the wrist and pinned to the coat. The upper arm is kept at right angle to the body, and the forearm flexed, fingers pointing to the pillow and palm facing inside of facing the side of the head. So the fingers, the hand, when you come back here, the hand will be brought back to the chest, and then this side will be turned, and these fingers will be facing up, and then they will be secured by a soft bandage. And then we shall instruct the mother to apply gentle massage to the arm in order to prevent contraction, and then also continue to observe for coldness and discoloration of the skin, because the bandage can be too tight and it might cause a disruption in blood flow. So we instruct the mother to always check on that, and for a period of time this baby's hand will go back to normal. So that is called an epispausi. That is called an epispausi, and the sign of an epispausi: 1, the affected arm will be inwardly rotated, the elbow will be extended, and the wrist will be pronated. And this baby will lack a Morose reflex, whereas it may have a grasp reflex. So that is a key sign to epispausi.